Hello, everybody. My name is Lindia Hayden. I am the co-lead with Pamela Abner of the Black Women Leaders Connect Employee Resource Group. It was launched about a year ago, Women's History Month in 2021. We support and nurture one another and have a vested interest in guiding women within our health system and our communities. I'll share the website in the chat so that you can learn more. It is our pleasure to collaborate with the Tisch Center today for this event. We selected this topic, the importance of colorectal screening. Let's talk about it for three reasons. One, March is Colorectal Cancer Awareness Month. Two, March is also Women's History Month. And three, we want to make the topic of preventive screenings easier to talk about. You know, not everybody likes to talk about it, but we're going to try to make it easier. Our panelists today are very familiar with this topic. Dr. Nikita Barai is a Senior Medical Director for Quality at Mount Sinai Health Partners, and she is in the Division of General Internal Medicine. Lena Jandorf is a professor in the Division of Population Health and Policy. And Michaelia Brown is a clinical research coordinator in the Division of Population Health and Policy. And I work in the Office for Diversity and Inclusion with a focus on disparities and data analytics. Our hope today is for you to learn from this presentation and this discussion and talk about it with your loved ones because knowledge is power. So before we begin, we're going to share a few fun facts or enjoyable facts about us. Just go from a serious topic to just a fun topic. And I'll start with me. So I was just telling the team that I like Brussels sprouts and I like sardines, and I'm just exploring different healthy options to eat as a lifestyle. And I put them together this week and they were delicious. I loved it. Some on the team could relate to it and thought that it was good, and others it's like, oh, that's interesting. You know, when people say that's interesting, they're not so sure, right? But we'd all like to share something near and dear to us. So I'll start with Lena. What's your fact?
I like to say that my favorite role in life has been being an aunt to my wonderful two nieces and nephew, and now great nephew. Wow. So it's always enjoyable to watch people, the kids grow up and become adults and out on their own.
Excellent. I love that. Family is so important, and watching them grow too. That's great. Okay, Dr. Barai.
I guess my fun fact, building off of both of yours, I have two kids who are 3 and 2, and eating vegetables, Brussels sprouts specifically, is a challenge in our house. And so we're trying to have them help us cook more. And so doing cooking projects with vegetables has kind of become a new fun task in our house. So
nice. Now with that, do you couple eat it or else, or just you decorate it on the plate, or just try effort?
You have to try it. And then if you don't want any more, you don't have to have more. But my older daughter has now turned into a broccoli eater. She won't eat anything else, but she'll eat broccoli. So
I love that. Yeah. When my daughter was little, she would say, I want the trees, the green trees, because that's how they look, right? Okay. And Michaelia, what's your fun fact?
Going off the same vein as everyone related to food, my fun fact is that actually for 7 years, I was a vegetarian. Not by choice. My mom decided to go vegetarian when she was pregnant with my sister because my sister hated meat. And then when she was pregnant with my brother only wanted meat. So therefore we broke being vegetarian for my brother.
Okay, cool. I like that. I have to talk to you to get some more ideas because I have meatless Mondays. So that's my day and I'm stretching it out for Lent to other ideas. So we will be in touch. Okay. So what we'd like to do with the general audience is to just take a poll. It's anonymous. We really want to know where you stand in terms of this topic. So as you can see on the screen, our question is, are you knowledgeable on colorectal cancer and the importance of cancer screenings? You have one choice, yes, no, or somewhat. So you can begin now. And again, it's anonymous, so please go ahead and make your choice. It helps us to have this discussion to know. So Corey, I cannot see the percentages from the screen, so just let me know when it gets to a good percentage. I can time it a little bit. All finished. Okay, so let's share the results. All right, so we have a mixture here. So 38% are saying that they are, which is good. I'll round that up to 40. 13% said no, and 50% said somewhat. So, okay, this is good. This is good. Thank you. Thank you for participating. So what we'd like to do now is to share a 15-minute presentation with you, and then we're going to have an open dialogue, which will include interactive Q&A. So please feel free to put your questions. There's a Q&A box. Put your questions in there and we will get to them. So Michaela, it's all yours.
Thank you, Lindy. I just want to thank you again for organizing this event, because we do need to share colon cancer awareness, not just across our staff and our family members in outreach, but again, in reach with each other, family, friends, even parents, our siblings. So to get started, I'm going to share my screen. Can everyone see the screen, just to confirm?
Yes.
All right. And so, like we said, today we will be talking about the importance of colorectal screening, and we're titling the TEL series, Let's Talk About It. So our goal today is to stress the importance of colorectal cancer screening, to understand different screening methods and updated guidelines for screening, because the guidelines did change during the pandemic that some people are not aware of, and additionally to increase enrollment for colorectal cancer screening. So here's a fun, I don't know if it's fun, but it's a fact that we like to point out before we start our presentation, is that in New York City specifically, only 62% of New Yorkers are up to date with colorectal cancer screening. So, and this is based on the age group from 50 to 75, so not even the updated guidelines for screening. So we suspect that this percentage might even be lower. So it's something to realize that less than 70% of those who should be screened are getting screened. And then another statistic we like to share is the age-adjusted incidence rates per 100,000 women that we see across races. So as you can see, with all races, we have about 33.3 women out of 100,000 are getting colorectal cancer, but then that number skyrockets for Black and African-American women. And then for white and Caucasian women, again, it's down to near the average of 33. So we're seeing that African-American and Black women are 20% more likely to get colorectal cancer than their Caucasian counterparts. Additionally, a little key fact is that the reason why we're stressing colorectal cancer and colorectal cancer screening is that the best time to diagnose colorectal cancer is when symptoms have not yet appeared. So when there's no sign that the cancer has spread and it's just remained in the colon or rectum. And we like to categorize this as stage 0 or stage 1, as you can see in this diagram over here. And so at this stage, we say it's also the localized stage. You have a 5-year relative survival rate of 90% if it can be found at these stages. Once the cancer has progressed to stage 2, stage 3, or stage 4, the 5-year survival rate does drop to 15%. And so one of the biggest reasons why colorectal cancer screening is so important as well is that while finding a colorectal cancer in stage 0 or stage 1 is so important, only 37.5% of colorectal cancers are found at this stage. And so we want to increase that number to 100%, where if you're getting colorectal cancer, you're catching it right at the start. That way it is not spread to any other organs. And then another statistic we'd like to share is the age-adjusted mortality rates per 100,000 women, where again, we do see that Black women are dying more frequently. In fact, it's 40% more likelihood that African-American and Black women will die from colorectal cancer than their Caucasian counterparts. So how do we start to combat these discrepancies? Well, one of the ways is by educating our communities and promoting screening. So to understand colorectal cancer, we have to first know what it is. So what are the colon and rectum? So the colon is also called the large intestine or large bowel. It absorbs the water and nutrients we intake, and it is the expanse of your abdomen, while the rectum is at the end of the large intestine, and that goes towards the anus, of course. And what is colorectal cancer? Colorectal cancer is a cancer that develops in the colon and rectum, and most develop from a polyp. So it can start from anywhere at the beginning of the tract all the way towards the end. What is a polyp? A polyp begins as a non-cancerous growth of tissue on the wall of the colon and or rectum, which can develop into cancer over many years. So when you may have heard family or friends say, oh, they found a polyp, this is what they found. It's typically benign, non-cancerous, but if it is left to slowly develop, it can grow into colorectal cancer. So one of the facts we like to share about colorectal cancer is combating some of the myths. So one of the things is that anyone can get colorectal cancer. For a long period of time, it was seen as a man's disease where women were excluded, but it is in fact true that men and women do get colorectal cancer. Again, colorectal cancer is one of the most commonly diagnosed cancers in the US. It is in fact the fourth most common cancer diagnosis after breast, prostate, and lung cancer. And lifetime risk is 1 out of every 24 persons will be diagnosed with colorectal cancer. But again, finding that cancer in stage 0 or even stage 1 and finding it early is the key to survival. And so because colorectal cancer is a slow growing cancer, research has changed and showed that there's earlier onset of colorectal cancer. So in 2020, the US Preventative Service Task Force changed the guidelines to include those below 50 and now starting at age 45. So for age 45 to 75, people who are at average risk of colorectal cancer, which typically means that you have no family history and family history relative to your first degree relatives, so any siblings, parents, grandparents, then you just need to, that's when you need to start getting tested, 45 to 75. Before age 45, for people at high risk, so anyone with this family history, you should start getting screened or having this conversation with your PCP. Ages 76 to 85, the decision again should be another shared decision-making opportunity between you and your PCP. And 85 and older should not be screened simply because of the vigorousness of the screening and diagnostic colonoscopies of the patient. And so some of the risk factors that we like to highlight in colorectal cancer is, again, the family history, of course, is a huge risk factor. Your diet. So there has been evidence that a high intake of red meat, so like a burger a day, has been linked to colorectal cancer in the same way that high sugar intake has been linked to diabetes. Physical inactivity, abdominal obesity, smoking, and alcohol intake are all also risk factors, but risk factors that you can change. And so one of the key facts of colorectal cancer is that it can have no symptoms, so we all need to be screened. So starting at 45 or earlier if you're high risk. So as polyps grow, they can cause any of the following. So there are some signs you can look out for. So bleeding from the rectum, blood in the stool, change in your shape of the stool, any cramping in your lower part of the stomach that is abnormal, feeling the need to have a bowel movement when there's no need to have one, constipation, or abnormal weight loss. And one of the common myths is if you don't have symptoms, you don't have colorectal cancer. And again, colorectal cancer is a slow growing cancer, so you could have no symptoms in the first 3 years as it's developing, and then come year 4, you have all these symptoms. So again, that's why screening is so important. Colorectal cancer is a man's disease. It is not. We are seeing women as well as men get colorectal cancer. And colonoscopies are the only way to screen for colorectal cancer. Fortunately, this has changed where there are additional tests that you can do from home now, instead of having to do a colonoscopy if you don't have the time or resources. So how do you get tested for colorectal cancer? There are a few methods to screen for colorectal cancer, which includes the screening colonoscopy, the fecal immunochemical test or the FIT kit, and then the FIT DNA, which is similar to the Cologuard that you may see in commercials. So one way that we like to think about these screening methods is 1-step versus 2-step. So in a 1-step, you are getting a diagnostic colonoscopy. You go in to check for any cancerous cells or polyps, and if you have any polyps, they are removed at the same time. Versus 2-step, it's where you use either the FIT kit or FIT DNA, which are both home tests, and only if there's a positive result, then you would go in for a therapeutic colonoscopy. So in the 2-step method, the therapeutic colonoscopy is only when necessary. So what is a colonoscopy? Colonoscopies are screening tests that examine the entire colon. So the scope will enter through the anus and rectum, traverse the entire colon, and then slowly backtrack as your doctor will look around to see if there's any polyps that need to be removed. Additionally, the colonoscopy allows for screening, diagnosis, and removal of polyps in a single visit. So if there are no polyps or abnormalities found, your next colonoscopy would be in 10 years. It takes about 15 to 30 minutes. There's light sedation, and the recovery is 30 minutes, so it's very quick outpatient. You arrive and you can go home. Additionally, there is some prep with the colonoscopy, usually in the days leading up to it, but after colonoscopy, you can eat. And so the FIT kit, which is one of the two-step approaches, is the fecal immunochemical test. And these are stool-based tests that you do at home based on 2 different stool samples, and then you send it into a lab where the results are then sent back to your PCP. And the similar method is used for FIT DNA. The distinction is that while the FIT kit specifically looks for symptoms like signs of blood in your stool, the FIT DNA looks for abnormalities of DNA, which would be caused by cancer or polyp cells. And so again, just to compare all the screening methods, we have colonoscopies, which are every 10 years, and the polyps can be removed during the procedure. The FIT kit is every year. If your results are positive, then you would need to go in for the diagnostic or / therapeutic colonoscopy. And FIT DNA is every 3 years because it looks more towards the DNA. And then again, if the results are positive, you'd have to go in for that colonoscopy. And when our polyps are removed, particularly precancerous polyps, you decrease the potential of getting colon cancer. And so in colon cancer screening, we do recognize that there are barriers. So there could be the lack of time. Maybe you don't have that 3-day schedule available for you to prep and not be eating. That's why you have the FIT kit and the FIT DNA test that you could potentially do from home. Lack of interest, which we want to nip in the bud, because colorectal cancer happens to all of us, happens to anyone. Doesn't matter if you're 65 or 45. Someone in your life may have colorectal cancer or may be going through a diagnosis. Anticipation, which is why we want to be able to provide you with all the education material, any resources that you need, connect you with folks who can talk to you about this decision. Cost, fortunately, we're addressing costs even now with our different programmings. Fear of getting cancer, embarrassment, fear of discomfort or pain during the exam. I've observed colonoscopies. I've heard people say they didn't even realize that they had it done because they went to sleep in one room, woke up in the next room, and it was completely over. Lack of importance of screening and treatability of colorectal cancer. Like we shared, colorectal cancer is treatable as long as it's caught early. You have that 90% survival rate at stage 0 or stage 1. And then lack of physician's recommendation, which is why we want to equip you with all this information. That way you are able to advocate for yourself. So here are some questions you can ask your healthcare provider during your next medical appointment, especially if you're now 45 or approaching 45 or have anyone in your life that's approaching 45. You can ask, is it time for me to get screened for colorectal cancer? Do you have any advice for me based on my family history? Recommend any special follow-up, which test might be right for you based on your life decisions and your life focus, and how long will it take to receive results? Who's going to notify me of the results? And how should I get an appointment? Again, always be proactive about your health. If you don't have a PCP or you feel uncomfortable just walking up to a random stranger, feel free to ask your GI specialist colleagues these questions. They're more than happy to help. So here's some methods when we're addressing the cost as a barrier on how to get screened. So at Mount Sinai, we have the CRC Choice Program, which is the Mount Sinai Colorectal Cancer Screening Program. And so this number, 212-824-7887, is a working number that you can call to get scheduled for a screening examination. It's for any individual from 45 to 75, so within the guidelines, who has not kept up to date with their screening recommendations, and you have no current signs or symptoms of colorectal cancer. So if you have health insurance, colorectal screening is covered by insurance with no out-of-pocket costs to the patient. But if you do not have health insurance, you are eligible for the New York State Cancer Service Program. And so the New York State Cancer Service Program provides breast, cervical, and colorectal cancer screenings at no cost to women and men who live in New York State. You meet the age requirements that are set by the USPTS, and then you have no health insurance or you're underinsured. So with the colorectal cancer screening available. Screening options available is a fit kit. So that's for anyone age 45 and older. Additionally, colonoscopy for men and women who are at increased or high risk. So multiple local clinics, health centers, doctor's offices, even Mount Sinai itself participates in this program. So feel free to call them at 1-866-442-2262. And that concludes our presentation on colorectal cancer. But before we finish, we just want to make sure that you're also aware that throughout the month of March, as it is Colon Cancer Awareness Month, we will be at different locations around Mount Sinai. So if you want more information, if you have colleagues or friends that you want us to stop by our table, feel free to join us anytime from 9 a.m. to 3 p.m. So this coming Thursday, we'll be at Union Square. Actually, on March 17th, we are now going to be at Morningside. March 24th will be at CAM. And then the 31st is our larger event, as you can see in this picture, which we'll have Guggenheim. We'll additionally have this rolling colon, which is a inflated colon that you can traverse. You'll be able to see polyps. Basically, you're acting as a scope. And our Guggenheim location will include resources from the IBD Center, endoscopy nurses, our CRC choice nurses, patient navigators, and health educators. So feel free to stop by. All right.
Wow, that was great. Thank you, Michaela. Do me a favor, can you revise in the PDF, the dates, and then we'll share it in the chat, because I don't want people to go to the wrong location. Where's the colon?
And I just want to add that the 24th and 31st are still pending COVID guidelines about gathering in those spaces.
Oh, okay.
So,
all right. So I guess we can put where they can go to find out the most update, because some people, they might be based at that hospital and they don't want to travel to another hospital. I'm at corporate, so I'm probably going to pick the one on the 31st, but we'll get back to you. All of the registrants, we'll send that information out to you as we know it. So thank you very much. I know that I learned a lot when we were preparing for this and I saw this presentation. And I'm hoping that everybody else did too. I feel that the biggest points were that there are no symptoms, right? So you need to get screened, and getting screened early can potentially save your life. And the second thing was about the CRC choice. I wasn't familiar with that. I'm not sure if others were, but there's a lot of important information in that presentation. So we definitely want to share it, because we recognize when we schedule these type of things, people have competing conflicts. They might not be able to attend. We're hoping that they look at the recording, but this is very important information and it's preventative. So what we'd like to do is to maybe talk about some case studies. Dr. Barai, would you like to share with us some case studies based on your experience?
Yeah, I mean, I think, I'm a primary care doctor at heart, right? So I sort of wear this other hat where I'm looking at quality, but, I think for me, the thing that all of the statistics, right, are they're statistics, but I think just keeping in mind the real world impact of these screenings. And so I had shared a story just recently of a patient I have who had declined colon cancer screening her whole life. She just thought she didn't need it. She felt great. She doesn't have any health problems, frankly, didn't have any of the other risk factors either. And then, at one point just wasn't feeling very well, went into the hospital for additional evaluation, and then was found to have advanced colon cancer. And so when we talk about colon cancer screening, I always think of her and how that it just really could have been prevented. And so, now has invasive chronic adenocarcinoma, we'll be getting surgery, we'll kind of be getting all of the treatments. But so I think just remembering that when we talk about screening in the abstract and kind of in the big picture, just that there is an impact to not getting screened.
Yeah. I'm glad that they lowered the age limit, because yes. I have a personal story as well with my neighbor who was just losing weight and not really feeling well. He was a big guy and he was 49. And by the time he went to the doctor, he hadn't gotten screened previously because I think the limit then was 50 and he was 49. And then he was at stage 4. And unfortunately, he did pass. So that prompted me to go get screening even before, I was 50. So thank you for sharing that. Do you have another story that can maybe say somebody who was hesitant and they did get screened? And
so many. I mean, I think it's really part of the shared decision-making process, right, with patients, really, and I would encourage all of you to have those conversations with your doctor, right? If you have fears, if you're hesitant, to really engage in that conversation. And I've never had a patient come back to me after getting a colonoscopy who said, like, how did you make me do that? That was awful. That's never happened. I think people feel relieved, and the way that I always counsel patients is like, if everything is good, you're good for 10 years.
Yeah.
And if they find something, you might have to get screened again sooner, but then like they found something that looked like it could turn into a cancer. And so that's a win.
Yes.
And so many more stories like that, thankfully, of people who've gotten screened and either it's completely normal or, perhaps there was a polyp that, we need to keep a closer eye on them. But I think there's always a little bit of relief for having done the screening.
Yeah, absolutely. Now, of your patients, do a lot of them do the FIT?
Yeah, so increasingly. So, I would say like pre-2020, we were not really using either of those tests as a significant sort of method of screening, but that's really changed since 2020. And I think it's really, Cologuard, in particular, the FIT DNA test has been a really nice option for a lot of patients. Colonoscopies are invasive. You need somebody to come with you. You need to, be fasting the day before or clear liquid diet. And so I think for some people, right, where this just doesn't practically fit into the reality of their life, this has offered a really nice alternative. And we're increasingly using FIT DNA in particular as an alternative method for testing. And that's good for 3 years if it's negative.
Good. Yeah, I see the commercials all the time.
Yep, they do have a very effective marketing campaign, but it sort of is well-founded in that it's a good screening test.
Yeah. And even with the tests, it's important to follow the instructions.
Yes.
About not eating. I actually made that mistake that I didn't follow it to the T, and I was told that it was cloudy. It wasn't as clear as it should have been, and I had to return in 3 years.
Yeah, for your colonoscopy.
Yes, for my for the colonoscopies. So even though it's hard, it's very hard for me to skip one meal, much less, not, and then drinking and but it's worth it. You want it to be clear so that when they're in there, if they can see some polyps or whatever it is. So I learned the hard way. I had to return.
Yeah.
So I do see some questions and I want to get to it. One of them is about foods, which foods to avoid, because I did speak about me eating more vegetables, but I am a meat lover. I do like steak. I like burgers. I don't eat it every day, but how detrimental is that? And coupled with exercise, do they counter each other, or what would you suggest?
Yeah. So, kind of with all things, right? Eating a diet that's rich in fruit, vegetables, whole grains. And then there is evidence that suggests that red meat in particular and processed meat have been linked to higher rates of colorectal cancer. So that's not to say, right, don't ever have a steak. If that's a food you like, don't ever have a hot dog. But I think really being mindful of cutting back on processed meat in particular and limiting red meat. And then limiting alcohol as well. That's another dietary factor that can impact your risk of colorectal cancer. Yeah.
All the things that I do.
Yes, all things in moderation, right? And with any of
these, moderation is the key. Yes.
The exposure threshold, right? Where if the more that you're exposed, the more likely you are to have the negative impact. So just in moderation.
Okay. So the specific foods to answer the question is
red meat,
the fruits and vegetables.
More, yes.
Limiting red meat.
Yep. Okay. And limiting processed meat, I would say even
like the deli meat.
Yeah, deli meats, hot dogs, bacon, any of the processed meats.
Yeah.
Yep.
Okay. So we have another question that says, does Mount Sinai remind us when we need cancer screenings to help so that we don't miss our screenings? That's a good one. Anybody? We have any
can take
alerts
that.
in the system? Let's blame it on the system.
Well, so we do have the electronic medical record, which, gosh, I don't know, must be 10 or 12 years that it's in place, maybe more. There is a health maintenance section that your typically your primary care, or for women, your gynecologist should be keeping up to date. We would love if there was an automatic reminder for every test that people should have coming up when, whether it's you get a message in my chart, or you're in front of the doctor and they get a message, oh, this person needs to, hasn't had colon cancer screening. It's not routine yet for every test. I think it's something, Dr. Barai, I think your group may be working towards. But right now, the onus is on each of us to be aware of our health, to be aware of, getting to the doctor. You do need a referral for most screening tests, whether it's in cancer or for diabetes, et cetera. So having that annual physical, which, now Sinai bonuses us for, right? We get a reduction in our healthcare costs if we do have that annual visit. So I hope that answers the question.
Yeah, I think it does. If it doesn't answer the question, please put in another one. And I think that once you do that annual, that's your reminder. Okay, it's an annual and it's thorough. And then you can ask all your questions, and your clinician also will be prompting. They know your date of birth, they know your family history, et cetera. And it is a two-way street, right? I mean, nowadays people go on the internet for everything to self-diagnose themselves, so it's a collective effort. Okay. I don't see any more specific questions. So I wanted to talk a little bit about one thing that Michaela had mentioned, and that was the barriers, the different barriers that she mentioned in terms of lack of time and the costs. We had mentioned about that there are some options out there. I mean, we're doing this as a health system and we are insured, but maybe some of our loved ones aren't. So that information will be good for them, that don't let the costs be a factor in this. Embarrassment. Let's talk about that. What's to be embarrassed about? Why do you think some people might be embarrassed? Anybody, open to anybody.
Yeah, I was gonna say, I think we have to be cognizant that we don't necessarily like to disrobe, get undressed in front of strangers. In some religions, it's, for women, it's actually prohibited. We actually do, fortunately, in the healthcare system, have many male and female endoscopists. So if there is a sense of embarrassment, again, they're all healthcare professionals, but you can request somebody of your liking. Doesn't have to be your same gender. Maybe you're a woman who would prefer a male. Definitely ask for that. That can be noted. Again, whatever screening, I think all of our radiology technicians for mammography are women. So I think we try to be aware of that, but have the conversation. Hopefully you have that comfort level with your primary care doctor and can talk about, well, this is why I don't want to go.
Yeah, I think that's an important point. I'm sorry, go ahead.
No, I was going to say super important point, Lena. It's sort of, I shared that I have toddlers, right? But sort of that idea of like, everybody poops, right? Like normalizing it, right? Like we all have these body parts and we all benefit from this screening. And then just remembering that the endoscopists and the healthcare professionals who do this, like they do this all day, every day. They're experts in it, right? They will hopefully be able to ease some of those concerns.
Yeah. And one that was on here was about fear or discomfort, pain during the exam. And it's really pain-free because you're under sedation. So you're not feeling anything. Matter of fact, when you open your eyes, you're like, when are we going to begin? Because you didn't even know that it's over, and it's fairly quick. So there's no discomfort there. I think that it's important that we included some of these things, because some of them, although they're valid concerns, because if it's a concern to a person, it's valid to them. Some of them are myths. I think that maybe we need to share more of that some of these things are just not true. Okay.
Well, and I will say that if you're of a certain age, and I will put myself in that category, before colonoscopies were as popular and as easy to obtain, there was something called the sigmoidoscopy, which only looked at part of the colon. It was not done under sedation, and it was painful. And so some people have that memory, or they know of people, well, they had that test and they put that thing up my rectum, and boy, it hurt. But that's no longer true. So if you're of a certain age and you've heard that, it's changed.
Thank you. I had no idea. I'm enlightened.
You're too
thank
young.
Thank God for modern medicine, that things have gotten easier. So for those people, for our audience who will be sharing it with their loved one, if somebody comes back and says that to you, then you can let them know that things have changed now, that it's not going to be uncomfortable, and they might feel uncomfortable, but it's not going to be painful. Okay, so what else do we want to share today to our audience to convince them that they should get screened? Not only for this particular cancer, but other cancers you work on, right? For breast cancer screening, there are other screenings as well. What else do we want to?
Yeah, I'll just say, for most cancers, we don't know what causes them. And for most cancers, early stages are asymptomatic. We don't have any change in our bowel movements. We don't detect any lumps in our breast. But we started this off by prevention. So the key to all of this is, in colon cancer, we actually prevent cancer. If we remove that precancerous polyp, we protected you from getting cancer in all likelihood. With mammography, because I'm sure there are many women on the phone, we can't prevent breast cancer. But again, the earlier it's detected, the less invasive the treatment is, and the more successful the treatment is. So again, you'll have heard of many people who pass from breast cancer or colorectal cancer. The key is early detection for any illness that we might encounter.
Yes, I agree. Thank you. So, okay, I'm sorry. Yeah, those were the same two questions. Okay, so let's talk a little bit about the disparities that Michaela had mentioned in terms of not just women, but also Black women, Hispanic women, white women. Do we find that some of these statistics have been rising? Do we find that they have been at that level for quite some time? Do we find that maybe there have been some up and down? We're on the downward trajectory?
I want to say, I will say that in New York City, the Department of Health did a great job over the past decade of reducing the disparity in who gets screened for colorectal cancer. That is not true everywhere. It's probably not true in our own healthcare system. We know that people of color, whether they're in the community or within our healthcare system, have lower rates of screening. Some of them are related, we believe, to these myths about cancer. And the mortality is partly biologic. I think Dr. Barai can say a little bit more. But it's also something called social determinants of health, that people, unfortunately, again, of color, have more barriers. So like we said with the colonoscopy, you need to have an escort. So that means you're taking the day off from work and somebody that you care about is taking or cares about you is taking the day off. That unfortunately is related to income, what type of job we have. You know, if you work at the local bodega, you're not getting paid for that day and you're asking somebody else not to get paid. So that's where stool-based testing really can have a very important role. But nationally, historically, it's something I think that the healthcare system works very hard at eliminating. It's why we have programs like the Colon Cancer Choice Program. New York State has free screening for breast, cervical, and colorectal cancer to help reduce that. But it's convincing our neighbors and ourselves to get tested.
Yeah, that's an important point, especially for people that they don't have a lot of PTO. If maybe they don't even have any PTO, you know, they get paid by the hour and that's just how it is. And, you know, you feed your family, you know, you have certain responsibilities. It is a hard choice. So Dr. Barai, have you come into that circumstance at all with any of your patients, any of these barriers that we had mentioned?
Yeah, I mean, certainly. So I think sort of, you know, a big one to keep in mind is access to care. And I think as Lena mentioned, you know, it's better in New York State than it is in a lot of places. But I think in other states, right, where they don't have programs that are as robust, I think access to care becomes a big barrier. And if you don't have access to care, you're not going to get screened. You're going to present right with symptoms that are then the result of advanced colon cancer, and that's going to affect your mortality. I think also access to care plays a role in terms of interruptions in care, right? Yeah. So if you have a patient who has an earlier stage colon cancer and is getting treatment, and then that treatment is getting disrupted because of health insurance concerns or other social determinants of health, that can play a role. And then certainly with other barriers, you know, I think Lena mentioned the challenges with just getting time off of work. You know, another particularly vulnerable patient population I think about is patients who are homeless, right? Where do you do prep for colonoscopy? There's no good place to do that if you don't have a home. And so I think stool-based testing has also been really helpful in making sure that those patients get screened kind of regardless of that other barrier.
Yeah. Thank you. Thanks for sharing that. So what we want to do now, I'm going to put a chat in the chat, the Black Women's Connect website for you to find out more about us. You can also view past events that we've had. They haven't actually been on a health topic, but there've been some interesting topics. So please feel free to go to the events page to look at some of those recordings. This session will also be on recording so that you can share the news to other people. It'll probably be out there within a week. And what I'd like to do is for us to bring up our second poll, because like I said, we wanted to make sure that we were sharing information and we want to know, has it resonated from you? So the poll question is on the screen. Again, it's anonymous. Has the knowledge from today helped you to schedule your appointment for screening and share the information with others who are 45 years and older? So please answer the questions. Yes, no, and somewhat. Okay, you can share the results. Ooh. Oh, we like to see that. Yes, yes, across the board. So that's good. That warms my heart. It really does. So what we'd like you to do, obviously, is share this information. We'll be posting the PDF shortly. We hope to see you at the rolling colon, as they say, so that you can see on the inside, you know, what it looks like, learn more about what we shared today, actually see a polyp. I imagine there'll be material that they can take with them as well to share with others. So yeah, wonderful.
And if I could just add, you know, one of the goals of the Tisch Cancer Institute is to do community outreach. So, you know, we're all connected with the healthcare system. There are many groups out there that are less connected. So Michaelia and others on our team are available to go out in the community, some in person, some virtual, and do education programs on topics like breast health, colorectal cancer, and in various languages. So if you're at all interested, I guess, Lydia, they can get to you and you can get them to us.
Sure, they can contact me or they can contact diversity@mountsinai.org. And normally those type of inquiries come directly to me. So yes, I can definitely share with them.
So if you're interested in a community event, we would like to hear from you.
Yes, yes. We actually have a community event that you and I had talked about that's coming up for, I think, prostate cancer, right? In the spring and the summer that we'll be sharing as well. Okay. Michaelia, are you able to add that? Excellent. Okay, so it's there. Okay, so thank you, everybody. It's been a pleasure to share this important fact with you about the importance of colorectal health screening. And I hope that you all go and get your screening and share the information with others. Have a great day. Bye. Thank you to all of our panelists. It's been fun. Thank you.